Hello friends. So the next topic that we have to discuss is the nasal polyps. Okay. Now there are two types of nasal polyps that we have to mainly discuss. Number one is the enterochoanal polyp, which we also call as AC polyp. Okay. And the number two are the ethmoidal polyps. So let us discuss what are enterochoanal polyp and what are ethmoidal polyp and what is the difference between them. Right? Okay. Now let's see over here enterochoanal. So the name itself is telling you that this polyp, enterochoanal polyp, also known as AC polyp, you see it starts from antrum. The name itself tells you it starts from antrum. Which antrum? Of course, maxillary antrum. Okay, right? Choanal. You see over here enterochoanal. So choanal, this polyp goes towards posterior choana. So it starts from maxillary antrum and grows towards posterior choana. Okay, right? Now let's look at the ethmoidal polyp. So the ethmoidal polyp starts from the ethmoidal air cells. So name itself is telling you it starts from the ethmoidal air cells. Right? Okay. Now enterochoanal polyp. It is starting from the maxillary antrum. We know the maxillary antrum is the largest air cell. Okay. In the nose, this is the largest air cell. This is the largest sinus. The adult volume we discussed is 15 ml. So maxillary antrum is giving rise to a polyp. This polyp is also going to be large. Right? So enterochoanal polyp is generally a large polyp. Right? Now remember, the antrum is one cell. There are not multiple cells. It is one single cavity. Okay. So therefore, the enterochoanal polyp is generally single and it is also unilateral. Right? Now the ethmoidal polyp, we just saw it arises from the ethmoidal air cells. Alright. Now these ethmoidal air cells we have already discussed in the anatomy. These are small multiple air cells. So what kind of polyps arise from here? We will have small and multiple polyps. Okay. And these polyps are generally bilateral. Right. So these polyps, they arise from the ethmoidal air cells. Anterior ethmoidal or posterior ethmoidal, there are multiple polyps. Now, where will they grow? They will come out anteriorly. So these polyps, they come out from anterior nares. Right? Okay. Now, what are the difference? Now, you see the enterochoanal polyp. This is a single, large, unilateral enterochoanal polyp. It is generally seen in and it is associated with infection. Okay, it is generally associated with infection. The ethmoidal polyp, on the other hand, they are generally seen in adults and these are associated with allergy. Right? Okay. So enterochoanal polyp or AC polyp is generally seen in children associated with infection, and ethmoidal polyps are generally seen in adults, they are associated with allergy. Remember, allergy is going to be bilateral. Right? Now, remember, if there is going to be allergy, now this allergy is going to be in both the sides. Remember, the mucosa is same on both the sides. So if we have allergy, it is bilateral. So therefore, these polyps are also bilateral. Whereas infection is generally more on one side. Okay, or infection will first have on one side. So therefore, these are generally unilateral enterochoanal polyps. Okay, let's look at some photographs. You can see this is a case of ethmoidal polyp. So we can see multiple polyp, 1, 2 polyp, coming over here. This is the middle meatus area. We can see the middle turbinate over here. This is the uncinate process and we have multiple polyps. Right? Okay. Now look at this photograph. Now this is a representation of enterochoanal polyp. So as we discussed, the enterochoanal polyp, it arises from the maxillary antrum, maxillary sinus. So where does the maxillary sinus opens? It again opens in the middle meatus. So the polyps comes out into the middle meatus. It may block the middle meatus, okay, and then it grows posteriorly towards posterior quena, and it may even hang in the nasopharynx or may even come down into the oropharynx also. So this is a enteroconal polyp. You see, it's a big polyp, right? Okay, let's look over here. Now you can see an enteroconal polyp which is hanging into the oropharynx. So you can even see a part of the polyp behind the soft palate, right? So when you ask the patient to open the mouth and you examine the oropharynx, you can see the polyp hanging from behind, right? So that is seen in case of enteroconal polyp. Now how will these polyps present? These polyps present as nasal obstruction. Okay, so the most common presentation is by nasal obstruction, unilateral or bilateral. Okay, you see, enteroconal polyp is generally going to present as a unilateral obstruction. Okay, whereas ethmoidal polyps are generally going to present as bilateral nasal obstruction, right? However, this rule is not universal. Why? Why? Because you see, if the enteroconal polyp, it goes into the nasopharynx. Now, if it is in the nasopharynx, it will block both the sides of the nasal cavity. So it can also present as bilateral nasal obstruction. That means the enteroconal polyp has now reached into the nasopharynx. Similarly, sometimes ethmoidal polyp, on one side they are small, on the other side they are big. So initially patient has unilateral nasal obstruction, which may in late stages convert into bilateral nasal obstruction, right? Okay, so it's not compulsory that they have to present with unilateral or bilateral, but yes, they all present with nasal obstruction, right? Okay, now before we go forward, let us understand what is the pathophysiology of polyp. Why does a nasal polyp forms? Okay, why does it form? So to understand that, let's go back to our basics. So we go back to the basics. We know that we have a sinus. Now let us assume this is one sinus. Okay, it can be any sinus cell. It can be maxillary or ethmoid or sphenoid or frontal, any sinus cell. Now this sinus cell we know is lined by epithelium. Which epithelium? Yes, we know it is pseudostratified ciliated columnar epithelium. Okay, so I'll draw some cilia over here. So these are the cilia on the pseudostratified ciliated columnar epithelium, right? Now this sinus, it opens into the nasal cavity. That is also all right. Now in the physiology, remember, we studied that the air goes in the sinus, in the air cell during expiration. Okay, during inspiration the air comes out, right? So inspiration the air comes out, expiration the air goes in. Now I'll remind you why the air is coming out. The air is coming out during inspiration because of negative pressure. This negative pressure, remember, it is created by Bernoulli's phenomena. Remember, we discussed the example of aeroplane. So this negative pressure is created because of the flowing air, Bernoulli's phenomena, and it has physiological importance. All right. Now let us say that there is inflammation in the nose. Okay, any kind of inflammation. So when I say inflammation, it includes allergy, it includes infection. So any inflammation. What happens because of the inflammation? Because of this inflammation, this mucosa, this sinus mucosa, it undergoes hypertrophy. Okay, it is swollen. It's a chronic inflammation, right? So because of this chronic inflammation, we know chronic inflammation leads to chronic hypertrophy. So what happens because of this hypertrophy? Because of this hypertrophy, the sinus opening gets blocked. So you see over here, the sinus opening is blocked. Now what will happen? the mucus secretion will collect inside the sinus. Anything else? Okay, you see, because this sinus opening is blocked and there is a negative pressure, so what will happen? This negative pressure will apply a pull over this opening and it will try to pull out the mucosa. So this mucosa which is at the sinus opening, it will start prolapsing out. Okay, so you see this mucosa is stretched, it starts prolapsing out, it starts coming out. So what do you see over here? Yes, you see that this mucosa is coming out and it is prolapsing out, and then it comes out and it forms a polyp. Okay, so this is known as nasal polyp. So what is a nasal polyp? What is a nasal polyp? You see over here, a nasal polyps is a prolapsed sinus mucosa. Okay, it's a stretched and prolapsed sinus mucosa. So sinus mucosa has been stretched, now it has come out into the nose. Okay, so this is known as nasal polyp. Right? Okay, now because this nasal polyp is formed because of the stretching of the sinus mucosa, these nasal polyps have a pale glistening color. Right? So remember, the nasal polyps, they have pale glistening color. They're pale and glistening. Right? Why pale and glistening? Because there is no blood supply. You stretch the mucosa, there is no blood supply. If you touch these polyps, there will not be much pain. Why there is no pain? Because they do not have nerve supply. So there is no blood supply, there is no nerve supply. So there won't be any pain if you touch it. There won't be any bleeding if you touch it. Okay, so no pain, no bleeding if you touch the polyp. Right? Let's look at these polyps once again. And what do you see over here? You see these polyps, this is the photograph, and you see that they are pale glistening. Look over here, this is the septum. Look how red it is. Okay, look at the middle terminate, it is red. Right? Okay, but when you see the polyp, it is pale glistening polyp. Why? Because there is no blood supply. If you touch it, there won't be any pain or bleeding from the polyp. Alright? Okay. Now, my question over here is, what treatment will you offer to this patient? So we have a nasal polyp. Okay? Patient has come with nasal obstruction. What treatment will you offer? Now you see, if I ask the student the questions, most of the books, especially the old books and the students, since they have read those books, they give me answer, sir, we will do polypectomy. Okay. Now let me make you understand what does polypectomy mean. Polypectomy simply means cut and remove the polyp. Okay. So what I can do is, I can take a forceps or a scissors and I can cut the polyp. So let me cut the polyp. I have cut the polyp, I have removed the polyp, and the patient problem is solved. He is able to breathe once again. The nasal cavity is clear. Okay. Have I done complete solution? No. Why? Why? Because we know just by understanding this pathophysiology that his sinus is still blocked. And unless I open this sinus, okay, unless I make this opening good, wide enough, the secretions are still there, the opening is still blocked, the negative pressure is still there, and that will lead to recurrence of polyp. Okay, so that will lead to again formation of polyp. So what do I need to do? I need to make the sinus openings wide. I need to open up these sinus. Unless I open them, problem is not solved. Okay, so now what do we call this surgery where we open the sinus openings? Okay, where we open them up, that is known as FES. Remember, functional endoscopic sinus surgery. So if somebody asks you what is the treatment of choice for nasal polyps, your answer is FES and not polypectomy. Right? Okay, the answer is FES. Remember, whether there is one polyp or there are multiple polyps, the treatment has to be FES, we have to remove the polyps, and then we have to make these openings wide enough so that they become self-draining and there is no formation of polyp, there is no recurrence, right? Okay, another question asked, what investigation will you do before doing the FES? Yes, what is your investigation of choice? Now you see, when I examine a patient, when I see a patient, I can see a polyp. Suppose there are multiple polyps on both sides, I know it's a ethmoidal polyp. Suppose there is a single polyp hanging in the nasopharynx or oropharynx, I know it's enteroconal polyp. So my diagnosis is made just by examination. Why do I need the investigation? I need the investigation to know what is the cause of obstruction at the sinus opening. So remember, we discussed in the anatomy, generally the cause of obstruction is some bony air cell, okay, anatomical variation. And for seeing those bony air cells, we have to do CT scan. Okay, which CT scan? Non-contrast, of course. Okay, so investigation of choice is non-contrast NCCT scan. Okay, right? Now, before I go forward, let us discuss a question over here. So, this question, most common site of obstruction by a nasal polyp of maxillary sinus. So, we just discussed the maxillary sinus, it opens in the middle meatus. Okay, so that is the place where this polyp will first obstruct. Okay, so this is the most common site. Of course, it grows, it can block the whole nasal cavity, then it can go to the oropharynx and nasopharynx, it can block in the nasopharynx, but the most common site is middle meatus, right? So this question was asked recently in the FMG August 2020 exam. All right, let's go to the next question over here, Cardwell Lux operation. So we have discussed Cardwell Lux operation earlier also. So what is Cardwell Lux operation? You give an incision, a sublabial incision over here. So you can see this is a sublabial incision, and you give this incision and then you make an opening in the maxillary sinus, okay, and you go inside and you operate. Now, after understanding the FES treatment, let us go and look at Cardwell Lux operation. So Cardwell Lux operation we have already discussed. We have discussed earlier. So what do we do in Cardwell Lux operation? You can see over here, we are giving a sublabial incision. Okay, and what do we do after giving a sublabial incision? We break the anterior wall of the maxilla, the anterolateral wall, and we enter to the maxillary antrum. Okay, now this operation, Cardwell Lux operation, was earlier done for enteroconal polyp. Okay, especially recurrent enteroconal polyp. Okay, this was done earlier, not now. Why? You see, earlier what was done for enteroconal polyp, before we have discovered FES, before we have discovered the endoscopic sinus surgery. So what was done for enteroconal polyp was that you will take a Killian's polypectomy forceps. Okay, so you will take this polypectomy forceps in the nose, it will grasp the polyp and then you will pull the polyp. Okay, so when you pull the polyp slowly and slowly, it was believed it will break from inside the maxillary antrum, it will come out and your problem will be solved. But most of the times what will happen? The polyp will break somewhere in between and the maxillary ostium will remain blocked. Okay, and when it remains blocked, what will happen? There will be recurrence of AC polyp. So recurrence was very common before we discovered the endoscopic sinus surgery, right? So recurrence was very common. So what will we do? Okay, because the patient is having recurrence again and again, so Cardwell Lux operation was done. Now in this Cardwell Lux operation, this maxillary antrum was opened and then the whole mucosa of the maxillary antrum was removed. So no mucosa, no polyp formation. That was the belief. So you remove all the mucosa from the maxillary antrum. That's known as Cardwell Lux operation done for recurrent AC polyp. Nowadays, we don't do it for AC polyp. Why? Because when we do the surgery, when we do the FES, we make the maxillary antrum ostium wide. Okay, and when we make the ostium wide, start. So when we do FES, we can remove the whatever the content of AC polyp is there inside the maxillary antrum also, right? So we need not remove all the mucosa of the maxillary antrum. Okay, so remember Cardwell Lux operation for AC polyp was done earlier. We don't do this surgery for AC polyp nowadays. We do FES only. Okay. Yes, Cardwell Lux surgery can be done for other indications nowadays. Such as I told you that you can do it for epistaxis. Again, for epistaxis, we generally do the endoscopic surgery. But you can do, if endoscopic surgery is not possible because of excessive bleeding, you can do Cardwell Lux over there. Or if there is a mass in the maxillary sinus and you want to take a biopsy from inside the sinus, then you can do Cardwell Lux operation. Okay, so there are other indications for Cardwell Lux, but recurrent AC polyp, again I will advise you, if such a question comes in your exam, what is the treatment? My treatment is FES. Okay, that means the opening is not wide enough. That is why the AC polyp is blocking the sinus again. So you do FES once again, right? Okay, next, oroantral fistula. I have already told you that one of the interesting complications of Cardwell Lux is oroantral fistula. This is a fistula between the oral cavity and the maxillary antrum. And how do you treat it? You again treat it by Cardwell Lux operation. So this we discussed earlier in the epistaxis topic when we discussed the Cardwell Lux operation. All right. Now, before we finish the topic of nasal polyps, we must remember that there are some other syndromes which are associated with nasal polyps. Okay. So what are these syndromes which are associated with nasal polyps? Let's have a very quick view, and these are the MCQs. All right. So number 1, Semter's triad, also known as ASA triad. So what do I mean by ASA? Number 1, aspirin sensitivity. So patient is allergic to aspirins, or you can say NSAIDs. Number 2, we have sinonasal polyps, and number 3, we have asthma. So ASA, right? Okay. Next, we have the cartilaginous syndrome. Now, what is there in the cartilaginous syndrome? Cartilaginous syndrome, we have situs inversus. So heart is on the right side, right? Okay. So situs inversus, dextrocardia, we have along with that bronchiectasis, and patient has chronic rhinosinusitis, right? Okay. Now, the next syndrome is the Young syndrome. So what happens in Young syndrome? In Young syndrome, we can see over here, this is the normal airway, and patient may have bronchiectasis, the airway is widened, there is mucus collection over here. That is because the patient has azoospermia. The cilia are not working, patient has azoospermia. Okay, and patient has chronic rhinosinusitis. Of course, because of the same thing, there may be blockage, and that may lead to chronic rhinosinusitis, which leads to polyp formation. Okay. Next syndrome that we have is the Churg-Strauss syndrome, which is also known as eosinophilic granulomatosis with polyangiitis. Okay. Now, this syndrome we have studied in detail in your pathology and medicine. I'll just go through very quickly. This is actually systemic vasculitis. It is a mononeuritis multiplex, and it has peripheral eosinophilia. It has late onset asthma. So these are the signs which are looking like signs of allergy, but it is actually a eosinophilic granulomatosis with polyangiitis. Okay. So let's look in this photograph. So what can we see? We can see patient has fever, patient has tiredness, malaise, patient has sinus rhinosinusitis. That can lead to polyp formation. Okay. Other than that, patient in the lungs have late onset asthma, patient has heart problems, skin rashes. So you will see small eosinophilic skin rashes. Patient has nerve damage. Okay. So that is known as pins and needles. So patient will feel there's a, patient is getting this feeling that he is being poked by pins and needles. Patient also has anemia, and there are muscles and joint aches. Okay. So these are symptoms of eosinophilic granulomatosis with polyangiitis, but you will be studying more detail about it in pathology and in medicine. I just wanted to tell you that this rhinosinusitis again is associated with nasal polyps. Okay. Next is non-allergic rhinosinusitis with eosinophilia syndrome. So this patient is having serum eosinophilia, okay, but the patient is not type 1 hypersensitive. When you will do an allergy test, you will find that the patient is non-allergic, right? So this condition, also known as NARIS, it is also associated with nasal polyps, right? Okay, and lastly, we have allergic fungal rhinosinusitis. We also call it as AFRS. Now remember, 100% of these patients, they have nasal polyposis. Okay, generally this nasal polyposis is multiple. Just like we see in the ethmoidal polyps, these are multiple, but remember, they are usually unilateral. So you can differentiate the ethmoidal polyps from AFRS, that these polyps are generally unilateral. Okay. Anyways, AFRS I will be discussing more in the fungal rhinosinusitis, okay, in the next topic. But yes, you should know that allergic fungal rhinosinusitis is also associated with polyposis, and that is in almost 100% of the patients. Okay. So these were the few syndromes which are associated with nasal polyp. So this question comes, which of the following syndrome is not associated with nasal polyp? So you must remember these few syndromes which I have told you, and if you remember the name also for ENT question, it will be mostly enough, right? Okay.